We're live.
Hello, everybody. Greetings from Confederation of Medical Association of Asia and Oceania, IT supported by Heartcare Foundation of India and Indian Medical Association. For me, it is 713th meeting in a row where, as a president of CMAAO, I have been interacting with people. And this will be 25th meeting for the CMAAO countries in a row, which will continue for another 1 year. We are expecting more members to join, but let me welcome Dr. Ravi Naidu, who is our uh, immediate past president of CMAAO. And I also have with me Dr. Sanchita Sharma. She is the editor of MedTalks Group, and who is also our editor to make all the notes and present it to all the countries. The topic we are talking today is three issues. When a lot of people joins, we will take a type A statement as an official statement because it has come. If any country has not sent it, we will discuss it as a joint statement to be released. Second is issuing of a CMAAO credit hours that we will be discussing. And third we are discussing is, then second is statement. So some correspondence from the CMAAO. But before that, let's take a short version on the current situation of the problem in the world. I'm taking up the problem in Asian countries, and I'm only trying to find out why the results are the best in Sri Lanka, what messages we can take. Unfortunately, they have never joined in our meeting. They have never joined in our meeting. Let me open that. WHO also has lauded efforts of Malaysia. They have lauded efforts of Pakistan. They have lauded efforts of Sri Lanka. Now in Sri Lanka, if we see here, in Sri Lanka, if we see here, there are total number of cases is only 3281. That is 153 per million population. Let me see, some people wants to join. If we have nobody from the international, check this 3530, maybe who is he, and then you can take them out.
Okay, just started Dr. Prakash.
Sri Lanka is 2,281 cases. And if I go back to yesterday, and then I go back to Sri Lanka, I want to devote some time. There are only 5 cases they have yesterday, only 5 cases, vis-a-vis 1 lakh cases in India every day. Total deaths are only 13. Total cases per million population is only 153. Deaths are only 0.6 per million population. Total tests done are 262, 378. Tests per million population are 12,242. That is per million population. If I compared it with number 1, India, total test is per million population is 44,523, which is double the number of tests done in Sri Lanka. And the death rate is 62 per million population vis-a-vis 0.6. Total cases per million population is 3,836, which is the total score of Sri Lanka. So what is there in Sri Lanka which is protecting themselves? Taiwan is 0.3. Taiwan, Hong Kong is 14. Thailand is 0.8. When it comes to Malaysia, it is 4. So there is something in Thailand which is 0.8. Vietnam is only zero point 0.4. Taiwan is only zero point 0.3. I'm only discussing countries where the mortality is less than 1 per million population. Can anybody tell us what is happening there? I'm reading the literature. The only thing which I'm getting is that they have the maximum number of healthcare providers in the world. That they have the maximum number of healthcare providers in the world. Is that the reason? I would like to put it on debate today. Why in some countries the mortality is less than 1%, 0.3, 0.2, 0.6%. If anybody wants to put their inputs here. Ravi,
Well, I believe that in countries like Malaysia, our healthcare system is quite well prepared. And I think we started off very early, and we have the healthcare workers with all the necessary facilities and also the precautions that are being taken. So I see probably that is the reason, in my opinion.
see, Australia is 33 per million population. So are we trying to say that Australia, I mean, in what way we are better than Australia? Australia is 33. And we talk about India is 62 death per million population. So somewhere or the other, Bangladesh is 30, Pakistan is 30 per million population. Nepal is yet to see a peak. So Nepal is 13 per million population. So I'm only trying to understand is we need to come back because it's 1 year is over. I wanted this to be an annual type of a review. That can we come back with some recommendation? What is the recommendation we can come back? Professor Nizami, you were also lauded by the WHO. Pakistan model was also been lauded by the WHO, Sri Lanka, Malaysia. So can you explain that because even WHO said Pakistan has been able to contain their disease much better than other countries. Professor Nizami, Professor Ashraf. Yes, can we hear from Dr. Nizami? You have to unmute yourself.
Thank you very much, Agarwal. It is my honor and pleasure to be here.
Your voice is slightly on the.
Kindly, let me make something.
Everybody, I'll request everybody to unmute because this is a small group.
Is it fine, sir?
Very, very low volume, unless. Otherwise, I have to amplify my sound.
Hello.
Yes. You can speak now. Professor Nizami, you can speak now.
Unmute. This is unmuted, I believe. If you can hear me properly, it will be great. Can you hear me, sir?
In the meantime, till the voice is corrected, can we ask Russell to talk about?
Well, I was just listening to you, KK. Australia is a bit unusual because that 90% is from one state, and that was the outbreak into the nursing homes. We are still going through this. In fact, yesterday or day before, Queensland said one day's death in Melbourne was what they had for the whole program. So it's a bit that's the thing. We've got this. It's coming under control now. Today's cases were 22 or so. That was all from and that tells us how difficult it is. So I'm not sure they from the rest of the part. 80, 90, I think they said 90% of that rates are coming from one state, and with this, which we have, which they
So
have
I
been
want to
taking.
say is that I want to say is prevent it as long as you can. You are only postponing the number of cases. Mistakes are inevitable. You make a mistake, you start getting it. Is that the final answer after 1 year of our CMAAO that vaccine we
Well,
don't know when it come, but at this moment prevent it as long as you can, because
yeah, but
any
I
mistake.
think, sorry, are we talking about also the age? No, the mortality and the age group that are where we're seeing the
See,
mortality.
I slightly after 9 months of my CMAAO presidentship
Yeah,
with COVID, with COVID, let me summarize few points. Okay. So I have redefined age. We used to call them as a biological age. I'm calling it as a immunological age.
right.
There is a terminology of a immunological age. What is your immune status? Is it the age of 40 or 70? I have myself have a patient, at least 100 patients who have 80 plus, who have carried the disease asymptomatic with comorbidities. Okay. So therefore you cannot say 80 years means mortality is high. I cannot. So I'm going to invite some people who may like to attend to our meeting. They are not members of NMAs, with your permission. They may be silently, they can watch this program. So all our people जो हमारे NMA के members नहीं हैं, please disconnect your photograph. You can only participate. You can only listen to us. So when it comes to age, there is also a immunological age. I am of the firm opinion there is immunopause. As you have menopause, andropause, there is also a immunopause. So if your immunity is lost, then only you are at a high risk, otherwise no. Second, my confirmation of the value is that if you have a baseline inflammation in the body, what we call them as high sensitivity C-reactive protein. So if you have a baseline mild inflammation in the body, that means your baseline CRP and IL-6 levels are low. In such cases, you are likely to get more complications. So it is predictable today. So I'm framing guidelines on this. It is predictable to define, even if you are 40, if you have a immunological deficiency, you are at a high risk. Even at the age of 90, if your immunological profile is okay, you are not at risk at all, even if you have comorbidities. So therefore, I cannot define only as the age. Somewhere or the other, it is immunological status, which is protecting or not protecting some people. If infrastructure and facility was the reason, then America should have the lowest mortality. Even if I say the mortality in Australia is in a particular community, but they still represents the country. They still represent the infrastructure of the country. So infrastructure, if you say that good infrastructure, then Pakistan would not have done better than other countries. Pakistan, India, Bangladesh have different types of their infrastructure. Our infrastructure cannot match Singapore and Hong Kong, but still we are getting 30 per million population mortality in Australia. We are getting more than 500 per million population mortality in Europe. So that cannot be the reason. Infrastructure cannot be the reason. The reason has to be somewhere or the other immunopause, a new terminology of immunopause. That means your immunity is deficient. And which immunity, what is the reason, we don't know. Somewhere or the other, it is a definition of an immunity. Some people say BCG, again linked to immunity. Some people say it is related to repeated infection, again it is immunity. Whether it is innate immunity or adaptive immunity, things are different. It may be a different types of an immunity, but it ultimately come back to a term called immunopause. So is there I was reading about Sri Lanka, Pakistan model, Sri Lanka model. I was reading Malaysia model. I was reading Japan model. So all those models when I'm reading, so the only thing I get is that in Sri Lanka, they have the highest number of healthcare providers, but they also went through lockdown. Every country went through lockdown. So lockdown cannot be the answer. Everybody has a law. Lawbreakers are there in every country. I don't think so. You will find lawbreakers will be the same anywhere level. If you say education is the answer, then I don't think so. Then UK, US, highly educated people, their mortality should have been lower. So I'm zeroed down to only one point is somewhere or the other immunity. I'm talking about immunopause, and I'm talking about more of a cellular immunity than of a. Now I'm finding people in, is it India, Pakistan, Nepal? Then what about Sri Lanka? What is typical in Sri Lanka that their mortality is much lower? If anybody has some experience of Sri Lanka, because they did that, they did the zero, they brought down zero mortality to malaria. They were the first one to control malaria in the country. I don't know. I don't know. In immunity, if we want to focus on immunity, then things may answer some of the unanswered questions. Age, no. See, if I see aged population is Japan. Let me see, Japan. Japan is also 12 per million population. Their mortality per million population is only 12 in Japan. USA, it is, then they should have had the maximum mortality, Japan. Why China has been able to manage it to less than 3 per million population? Number of cases in, so is it, if we are going to see that these people are not making mistakes, I can't understand that. That people in Sri Lanka are not making mistakes. Dr. Pillai hasn't come here, otherwise we would have asked about Kerala. So is this disease inevitable? Is this disease inevitable with every mistake? You make a mistake, you end up getting it, and you can postpone it by not making mistakes. Is it like typhoid? Is it like typhoid and jaundice, which disappeared in Europe because of hand hygiene, because of hygiene? Does it tell us the respiratory hygienic status of the society? If that's so, India would have got the maximum cases because respiratory hygiene is not here. But still, number of cases are much more in USA. So I'm zeroed down to immunological in my consensus report. If anybody has some other suggestion, tell us. After 9 months, I have zeroed down to aging, no. Infrastructure, no. Somewhere or the other, we are talking about cellular immunity. Now, let me tell you one thing to share, which is interesting, which all of you can quote in your respective countries. In Delhi, the third seroprevalence unofficial report is available. And let's take only Delhi as an example, because that's where all the research is going on. 33% people have antibodies positive, officially now. That means third sero survey, first sero survey, second sero survey, third sero survey. The population who has got IgG antibodies are 33%. Parliament has opened in India. 700 member of parliament from all across the country. Before they entered the parliament, RT-PCR was done, 3% positivity rate. That can be taken up by most of the countries as an example, that at any given time in a country like India, 3% people are positive. That means as on today, there will be 4 lakh people who are positive today, as on today. As on today, 3%, because all parliament, 3% of them were positive. That means they were infectious as on today. Another seroprevalence study has come is that 30% of the people who have developed infection do not show antibodies. That means 33% people have developed antibodies, 8% of them have not developed antibodies. So 41% people of Delhi are positive, have developed infection. 3 are positive today. So the prevalence rate is 44%. That means there are multiple models. Now this model is different from Sri Lanka model. Sri Lanka model is prevent, 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 and prevent yourself. And you can come back to a mortality of 0.3. Delhi model also says the mortality is 0.3% with 44% people involved. That's what I'm trying to differentiate the two models. If I take this as a model of Delhi, that 44% of the people have already got infected, then the mortality of Delhi is 0.3%. The second model is that you don't allow the disease to occur in the country, then the mortality is 0.3%. So the actual mortality is it 0.3%. So therefore, if you take Pakistan also into the picture, and if you calculate their prevalence rate, number of people, number of death, it will again end up into 0.3%. So if you calculate the not number of people tested, so if you see number of prevalence, as last time Pakistan told that so many percentage of people are seroprevalence positive, convert them into whole population, number of positivity, and then decide, calculate the number of deaths, the death will come back to 0.3%. So I want to say on behalf of CMAAO, from CMAAO, is the death of this, actually speaking, is 0.3% in CMAAO countries. Even in China, when I took, they said for every 1 case, 30 are asymptomatic positive. Their 3% also becomes 0.3%. So everybody is talking about what 2%, 3%, 4%. In that particular situation, I would say the mortality is only 0.3%. Any changes? Anyone who wants to? Want to hear from the people? Yes, Dr. Chong is here. Our chair is here. So once we finish this agenda, we want to have a couple of agendas with the chair. So Dr. Chong, I just said is that I just narrated because first part of today's meeting, I want to sum up. And the sum up is that the mortality in Sri Lanka is 0.3 per million population. Pakistan has been able to quite control, manage some resurgence of cases in Australia, some resurgence of cases in Malaysia are happening. But based on China and Delhi study, I'm not talking about India, I'm only talking about Delhi, because Delhi itself is a full country as far as the population is concerned. So if I take Delhi and Sri Lanka into consideration, Delhi has shown 33% seroprevalence rate. 3 different models confirm the same. So 3 different studies confirm the same. 33% of the people have got infection already. 3% of the people at any given time are positive. That's the RT-PCR survey. And 30% of the people who have developed infection have not shown antibodies. So in total, it comes out to be 44% of the people have already got infected or they are infected. With the current mortality, the total mortality comes out to be 0.3%. And that's the mortality of Sri Lanka with minimal number of cases. That's the mortality of China. If you convert 1:30 ratio, the 30 are asymptomatic for every symptomatic patient. So I want to say is that instead of saying that the mortality is 1%, 2%, 3%, we should be talking about the mortality is 0.3% and the mortality is higher in symptomatic cases. If we combine symptomatic and asymptomatic cases, the mortality is less than 0.5%. That was the first part of my meeting. And the second part of my meeting I want to talk about is Dr. Chong has been asking for CMAAO credit hours. So my office will start issuing. All of you, we will be giving CMAAO credit hours. So for every meeting, we will issue 1 credit hour to all the members who have attended. Kindly submit your attendance to Saurabh so that we can issue CMAAO credit hours. This we can get it passed in the next year's assembly because till today we have not been able to give it. But we will start giving CMAAO credit hours to every member. So kindly submit your number of days so that we can write down on the certificate. This is to certify that. And so many credit hours are awarded to everybody who has been attending. So Dr. Chong should get it, Saurabh, by today. Once he submits the number of meetings, practically he has attended all the meetings. So he can be given 25 credit hours. Today is the 25th meeting. So you can give them the credit hours issued, make a credit hour certificate and give it to them. Third is a request has come from the headquarters, from the secretariat. And the secretariat has asked all the people to submit the names of their counselors. So if you have not submitted, kindly do it. The president is Dr. K.K. Agarwal. President-elect is from Tai Yuan Chayo from Taiwan. Immediate past president stays Ravindra Naidu. First vice president is Muhammad Ashraf Nizami. Second vice president is Mustafa Zalal Muhyiddin from Bangladesh. Chair is Dr. Chong. Vice chair is Dr. Ko. Treasurer is Dr. Chan. Secretary General is So Hashimoto from Japan. And these are the counselors list we have got. If anybody has any change, kindly send it to the headquarters. They wanted to get it early. Send it immediately. If there is any change, kindly send it immediately for that report with that. Now coming back to one statement which they have sent is, they have also sent all of you might have received a statement of Taipei. Taipei has sent us a statement, and that is this is the CMAAO Taipei statement. I would like, if any country has not sent it, can we discuss it here so that we can finalize it here? Dr. Chong? What I was thinking was if I share it here, we can finalize this officially. So all the countries who are present here can sign it. So Dr. Chong, can you take the lead?
Yes, President.
What I mean to say, instead of
Okay.
every country sending it, we can combine it together and send it to them.
Yes. Okay. I think it's quite a lengthy thing. So why don't we just go through it fairly quickly? So preamble is there, and preparation would be. Let's
Just
look at the
read out. Just
preamble.
read
The
out, and
preamble.
if you want to change anything, you change.
Okay. Over the past centuries, human beings have overcome poverty, famine, and war to evolve into modern society. The SARS outbreak in 2003, H1N1 in 2008, Ebola in 2014, and the recent COVID-19 pandemic demonstrates that emerging infectious diseases have overtaken nuclear weapons as the most lethal threats to the whole world. Well, maybe we don't need to say nuclear weapons. As almost important health guardians, physicians play
I
pivotal
want to check it
role.
have overtaken as the most, and the recent pandemic demonstrated that emerging infectious diseases have overtaken many
Most
other
threats.
diseases.
Yeah, most
Many
threats.
other diseases.
Yes. Yeah.
Mm.
Yeah, I think forget about the nuclear weapons bit. As utmost important, health guardians, physicians play pivotal role in containing and mitigating the spread of infection to maintain the well-being of the society. No need for whole society. Society is just enough. Establishing an effective medical network enables infectious disease cases to be diverted at community level and reduces impact on the healthcare system. True. Furthermore, NMAs and the government each has its own respective important functions and roles. This statement calls for a collaborative work of all parties concerned for preventing and managing novel infectious disease in all aspects and curbing the pandemic and hopefully curbing the pandemic today. Currently is better. Currently, nowadays is a bit, currently, yes. Okay, preparation before pandemic. Clinics should stock PPE for pandemic. Physicians should receive CME and training in pandemic prevention and infectious diseases. Response to a pandemic and spread, maybe not spreading and spread. Implement history taking with travel history, occupational history, contact history, cluster of infections, and to report suspected cases accordingly. To provide health education to comfort the biopsychosocial aspects of community citizens and promote health literacy. I think provide health education to comfort or to enhance would be better. No need bio, just psychosocial health of community, community and its citizens, and community and its citizens, and to no comma, and to promote health literacy. To keep close contact with medical associations, to improve close contact with fellow medical associations, to enhance close contact with fellow medical associations, to report demand and shortage of PPE and medical information relevant to the pandemic. Okay. To apply big data, artificial intelligence, point number 3, to apply big data, artificial intelligence and medical information technology. Yeah. And from the NHI in the Taiwanese model, which has proved effective in diagnosing patients and contact tracing sources of infection. All right. When the number of cases increase rapidly, primary health care physicians should immediately upgrade PPE and reinforce the integration and coordination with designated medical institutions. I think that's fair enough. Next is establishment of a tiered medical system, response to a pandemic and spread, no spreading, I think, and spread. Provide primary care health infrastructure for community surveillance and referral of suspected cases, promote remote medical consultation and physical condition monitoring from home quarantines for home quarantine patients. Maybe home quarantine patients would be better. Point number 2, for home quarantine patients. Home quarantine patients, yeah. Can without the S, the quarantines without the S. Yes. General clinics should adopt telemedicine and prescription for patients with chronic illness to reduce risk of disease transmission. Yes. Prepare clinics with ample support. Prepare clinics with ample support. Prepared clinics with ample support should safely handle suspected mild cases and provide referrals. Okay, that's fair enough. When the cases increase rapidly, primary healthcare providers should be capable of handling suspected or confirmed mild cases. I think full stop. No need to advise to switch to telemedicine because we've already talked about that previously. Yeah.
Excuse me, this is Alvin speaking. I think, may I suggest also then for point number 3?
Yes.
For the same purpose, I think it could adopt telemedicine. I think the same thing is to be careful. Sometimes telemedicine could miss something if we do not have the physical examination of the patient. So it's not a must that we have to universally adopt telemedicine. Only those who really could not visit the clinics or we fear about the disease transmission, of course, we have to adopt telemedicine. But if we generally use a should here, it means universal.
Yeah. May is good. Yeah.
In any way, it was should,
right.
not shall. Should means
Yeah.
optional. The word should in
Yeah.
any way is optional, but I've clarified it should oblique may.
Yeah.
Okay. I think may is better because may leaves an
yeah.
option open.
I think may is a better word. Yes, may.
Yeah, may leaves
Yeah.
because should legally is compulsory.
Yeah.
Okay, let's move on to preparation
Thank you.
before a pandemic. Thanks, Alvin. Point noted. Safety stock of PPE, traffic flow of infection control planning, preparation of intensive care unit and emergency equipment. I think these are all fairly straightforward. Response to a pandemic and spread, not spreading, and spread. Accept referrals and provide care of patients with confirmed diagnosis and accept referrals and provide care of patients with confirmed diagnosis. Provide care of I think forget about that. Yeah, the second phrase. Yeah. Provide telemedical care for patients with confirmed diagnosis and quarantine and home quarantine. Yeah. Opt if possible, yes.
Opt where possible.
Yeah, to provide. Opt if possible, where possible, to provide telemedicine, to provide. President, to provide, yes. To provide, yes. And with confirmed diagnosis and home quarantine. With confirmed diagnosis, I think cancel out the quarantine at home. Yeah. Yeah, quarantine at home, I think. With confirmed diagnosis, on home quarantine, maybe on home quarantine would be better. Cancel and on home quarantine, yes, that's better. Yes. Maintain medical care capacity, reduce unnecessary, well, I wouldn't say unnecessary, postpone elective surgery and treatments rather than reduce unnecessary. Unnecessary sounds terrible. Consider postponing elective. Elective and operations and treatments.
Elective surgeries, I think, would be better.
Yeah, elective surgeries and treatments. Can postpone, but emergency obviously difficult. Yeah. And procedures, yes. Procedures and surgeries and procedures, surgical procedures. And I think the second phrase only provide other specialized. The second phrase is not very helpful. Yeah, not very helpful. Okay, when the number of cases increase rapidly, redesign facility layout to admit more confirmed patients with severe conditions. Obviously, that is reasonable. Telemedicine to relax regulations. I think again we have to be careful about telemedicine because it's not one thing fits all. So telemedicine to adopt appropriate regulations rather than relax. Relax sounds yeah. Consider, yes. Yes. Providing telemedicine, yes. And then maybe to adopt, yeah, to adopt, consider
Appropriate, I think.
appropriate,
Yeah.
yeah. Not relax sounds very bad. Yeah.
Yeah.
Relax sounds very bad. Appropriate. Yeah, relax sounds very bad. Appropriate, yes. Yeah, that's right. Forget about the relax. Yeah. And establish reasonable payment standards. Yeah, I suppose. Yeah, just consider appropriate regulations. Yeah, forget
Remove
about
the
the
relax.
yeah,
To
the
remove
relax.
the relax. Yeah.
Yeah, the relax have to remove the relax.
Delete the relax, I think. Have to.
Yes.
Delete it already.
Yeah. Yeah. Okay. Yeah, delete the relax. Yes. Okay. Consider. And engaging a medical education undergraduate and postgraduate. Response to a pandemic and spread, again, no spreading. Develop updated online courses, yes, that's fair enough. To deliver effective medical knowledge and clinical skills for better patient care, that's a given. Select a secure online teaching platform, work closely with information. I don't think we need to tell them what to do about, just delete the second part of it. Work closely with, I think no need to tell people what to do. Just select a secure online teaching platform. Yes, I think all this is just telling people what to do. I think that's really not necessary. I think we delete the whole point. Because it's all about telling people what to do. I think it's not important.
Well, but I think point 2, just to remind us that the cybersecurity is important while we are promoting the online CME, I mean medical education. Yes. Well, perhaps it's good.
Okay, just secure online teaching platform. Okay, that's good. I think that's enough. Yeah. Facing the harsh realities of the outbreak, many countries had to close schools. Reassessment and planning are needed to resume students' education, to gradually open campuses and take additional measures in response to the pandemic, such as restricting large-scale quarantining international students and helping patients self-manage their own health. I think the last part about helping self-manage their own health, I think is quite redundant, right?
Come back again.
The last phrase of point number 3, the last phrase, help students manage their own health. I think that's maybe that's not the last part.
The outbreak may continue had to close schools. Resettlement and planning are needed to ensure students' education. Can I take it out, the whole thing?
Yeah, I think the whole thing is actually just more for the education ministry, right?
Therefore, I'm saying medical school I can consider, right? So facing harsh realities of the outbreak, many countries had to close medical schools.
I think they're talking about general schools, not medical schools, are they? Or medical schools? Yeah, medical schools, yes. Yeah, medical schools, yeah. Because the heading is about undergrads and postgrads, yes. Yeah, medical schools. So reassessment and planning needed to resume students' education to gradually open, such as restricting.
Reopen campus and take additional measures. in response to the
Response to the
pandemic.
pandemic,
That's all.
yeah, such as restrict, yeah. I think that's enough. Yeah, the rest are all quite redundant. Okay. Actions during convalescence of a pandemic. Do we want to talk about that now, or I think we're still in the midst of the
Re-examine core
pandemic.
competence of postgraduate year PGI training, ensure training of emerging infectious disease care is tightly integrated, integrate community resources, develop interprofessional education. Let it continue. Now come back to role of medical association.
Yes, role of medical associations.
Preparation before a pandemic, assist the national authorities in continuing monitoring of pandemic and formulation of case reporting. Respond to a
that's, yeah,
pandemic,
yeah.
assist the
Yes.
national health authorities to distribute PPE in feasible and
Yes.
effective way to increase the coverage, strengthen the public outreach, timely release of accurate pandemic information, strengthen international communication. This is
Yeah.
fine.
Yeah, this is fine. I think it's good. These points are quite relevant. Role of the government. Do we really need to tell the government what to do, or is this important to recommend to governments what to do? I think some of these are quite reasonable. They are quite reasonable things. Share and exchange experiences, blah, blah, blah. When the number of cases should make
Role
reasonable
of,
use. I think the points are quite reasonable. Most of the points.
I only want to change the heading.
Actions.
I only want to change the
Yeah.
heading.
Yes.
Well, I echo Dr. Zhong's consideration whether we have to teach the government to do anything.
What to do?
Especially when we put down the points here, that means if they don't do this, the medical associations need to remind them or
Yep.
reprimand them. But I think
I'm
different
thinking-
government might have different things to do. Say, for example, in Hong Kong, we had just carried out a universal community testing program. And in fact, the World Health Organization had commented that it's not really cost effective to do a universal community testing. So would we advise the governments to do it? So in Hong Kong, we have done it, but then it's cost effective. Even WHO won't recommend it. And then on the other hand, would we consider it to be an occupational disease? Now that is the role of the government. So whether it should be an occupational disease, it is the legislation to be done by the government. Do we think that when health workers and doctors got the disease, it affected his health, could kill him, so or could cause all the income loss of the clinics? Then if it is an occupational disease, then of course it benefits the doctors who had got sick. So do we think it is important to include it?
So I'll modify this. Give me some time. I'll modify these areas where the government may work with the NMS.
Yeah,
Or
because
where the NMS may assist the government. Where the NMS
may work and assist. Yeah.
Where the NMS
where the MMAs may assist the government. That's a good. Yeah, that's a better way. Yeah.
Yeah.
Then you are not.
Yeah.
You are offering.
Let's not tell the governments.
You are offering.
Excellent. Excellent.
Yeah, excellent. Yeah. Okay. So, President, after you've gone through everything, are we completed? Is there some more below?
No, the last.
Okay. Okay. So, President, after you've gone through it, I'll go through it again with President, and then we'll submit it to everyone to have a last look before we send it back to Taipei.
Mr. President, may I suggest that if we really have to issue such a statement, I think procedurally we need to. I really just raise this point for consideration.
Let me clarify certain things. One is that I have not made this. This has come from Taiwan. This note has been prepared by Taiwan for their next year. Every time they give a topic, so this is a topic for Taiwan. They have given this as a Taipei statement. It has come to all of you from the Japan Secretariat. They wanted us, each country, to send it to them. It has not gone to them. So therefore, I thought of taking it here jointly. Then we can say at least these countries have gone through it jointly and we are sending it to you. So this is not created by me. This is not made by me. This is a type. Every year when the new country takes over, they give a statement. So this is the statement they have given. Next year, so this becomes the theme of this year. Last year's
Yeah.
theme has gone, so this becomes a theme of this year, which we are carrying on as the president and the current body. So this theme has been sent to, this was sent to all of you on second week or third week of August. We were supposed to respond. I got a reminder that people have not sent it back. So I thought of taking it here. This is an official statement I have taken, sent by the secretary. And this statement will be submitted to WMA as the theme of this year. That means
Yeah.
next year symposium will be on this subject.
Yeah, Mr. President, Hong Kong Medical Association had our council meeting discussed on this topic. We don't give any comments at all because, first of all, about the sensitive paragraphs at the bottom of the statement, especially. And secondly, is that because at that time of our council discussions, there had not been any council discussion in CMAAO to have this statement. So as you said, it's raised by Taiwan only. So procedurally, I think today, Mr. President, you are very right to raise it here. So at least we need to have a proper council meeting, even by WhatsApp or email circulation, that the council want to have a statement, and especially COVID-19, it is relevant. But it is a decision of the council meeting and not Taipei.
I'll request the chair to arrange for a council meeting by a virtual council meeting. All the councillors we have, you can ask to the secretariat and take it up in the council meeting. Let's have a virtual council meeting. We should have done it earlier. Let's have a council meeting every 3 months, and let's the decision be passed in the council meeting.
Yes, thank you. And if there is discussion
I will put it down officially to them that the chair will ask for a council meeting, write to the new secretary, and ask for a virtual meeting. It's possible today. There are no expenses, zero cost, no lunch cost, no dinner cost. We still can have a little bit of after the meeting entertainment for half an hour.
In fact, Ashraf had talked to me. In fact, Ashraf also had asked whether the meeting would be just, the Taipei meeting could be just postponed to December or really next year. I think it's quite difficult to be held this year, December. It's really difficult. Must be postponed to next year.
This has been postponed. This has been postponed, but we can have a council meeting, midterm council meeting. We'll call it a
so
meeting.
If we are not going to have a Taipei meeting this year, I would object to having a Taipei statement. Sorry. Okay. I would suggest to have a CMAAO statement, but not a Taipei statement, because it's not yet AGM in Taipei at all. Dr. Agawa is still the president, not the Taipei president.
Okay, so we'll do that. Then let me and Dr. Chong handle this issue. But that's a good idea to call for a. I'm not talking about a council meeting. Let's have a council meeting every 3 months. Like we had, we have a NMA meeting occurring. Let us also have a council meeting, whether they are informal or formal. At least we can meet and discuss. Thank you, Chan, for your Elvin for your suggestions. And so we have discussed most of the issues today. We have discussed the issue which has come to us. We have also discussed the issue of CMAAO credit hours. And another thing is, Ravi, if you are here, Ravi, when you are, I'll talk to that officially to the MMA. Anything else anybody wants to say? I will like everybody to say for 2 minutes about their respective country. Dr. Nizami. Dr. Nizami.
Something has gone wrong. I don't understand. I try to unmute and do everything possible. But
now it is coming. Your voice is less, but it is still coming. You are into a mild. you are into a mild. This is called as IT depression. So you become. So the answer is to become hyper. You go into IT anxiety.
Something
Speak
is
loudly.
wrong. Just I wanted to state that on this statement, we should must consider about the rights of the medical professionals, especially, I'm sorry, that is something is wrong. Something has to be said about the rights of the medical professionals and doctors community also. This is simple my suggestion, if we may include in it too, in the statement or the.
Yes, now you are forceful. Yes, I can also suggest Ashraf, Dr. Nizami, to think of yours what theme you want 2 years from now.
Okay.
That means next to next year theme, all of us can start working on it now. That becomes your year. Why should we only discuss it during the AGM now? Once we are meeting, you announce your year work so that you start working and you have 2 years to prepare. Pakistan MA has 2 years to prepare. Even Bangladesh can come back with their theme and start working jointly. We can really come back with some research papers which we can publish.
Okay.
Another thing is I'm looking now, all of you are a part of International Journal of Pandemic Research. Even if anybody has papers, views, reviews, kindly submit it to us because we are going to publish them as Asian resource. Asian COVID resource we want to develop. So anything they want to share something, we give your experiences, case reports from your NMA, from your doctors in the country, start sharing it to us. With that, Dr. Russell, then Mary,
Yes.
and Ravi, and then our Nepal fellow has gone, I think. Yes. Russell.
Well, from Australia, we are getting the second wave under control in Victoria. Probably another week more of the lockdown. The death, the mortality from the aged nursing homes continues, but the numbers of cases have come down, and so we're on that. That's what's happening. But again, the rest of the country, it's pretty much only Victoria has had 23. The others have probably no cases at all. So that's as far as Australia.
Anything from Japan?
Yeah, thank you all for everything. Japan trends to come down in second waves as well. The mortality rate is lower than in the first wave. We now expecting the flu influenza epidemic also. So we have been preparing for this, and we hope you will continue to find the information. Then thank you very much for your great help. Thank you.
If nobody else, I'll request the chair to close the meeting.
Mr. President, sorry.
Yes.
I just have a short report. In Hong Kong, we had done the universal community testing program from the 1st of September to the 14th. And then within these 2 weeks, we had screened 1.78 million citizens and revealed that there were only 32 new positive cases from this entire program. However, we think that the cost effectiveness is not just for those 32 new cases discovered. We could at least now understand that the whole situation in Hong Kong is really subsiding for the third wave. That is, every day now we have only single-digit new cases, although sometimes we still have a few with unknown origin, but still it's very few now. And occasionally we have only 1 or 2 cases. So we are relaxing all those social gathering limitation and restrictions. The schools are reopening, and the Commerce Secretary had considered to reopen the border with a few countries as pilot study. And then we are considering some health codes so that we could not only just cross the border to mainland China, but then perhaps as a measure to reopen more commercial entities, the restaurants, those gyms, and those bars, etc. So we are also asking the Labor Secretary to seriously consider COVID-19 as an occupational disease. Now that it seems to be it's not going. We expect that it would stay with us for at least a couple of years or even more. So we have to consider it as an occupational disease. And so we also find it not easy to secure some vaccines. We are not so lucky like Singapore that they produce their own vaccines. But in Hong Kong, it depends on mainland China and Europe and America. But every country, we will expect to satisfy its own demands first. So Hong Kong, we are keeping our fingers crossed whether not this year, next year, we could really secure enough vaccines for our citizens. So I hope India or other countries, if you are also producing vaccines, well, hope that the vaccines could really supply to those developing countries. So in CMAAO, perhaps we could look for India as a supplier sometimes. So in any case, we are expecting the fourth wave. We have discussed with some scientists in Hong Kong. I mean, those medical epidemiologists or infectious disease specialists, they just consider a new wave by the number of cases. I mean, by the curves. So not necessarily, but by definition, they said not necessarily some new strains, but obviously there are constant mutations expected in this virus. So, but anyway, they just think if there is a surge of a big number of new cases, then they would call it a new wave. Anyway, so we are expecting one after December, the fourth wave after December.
So I just want to understand, you said 1.78 million people tested, 32 positive.
32 newly positive diagnosed cases.
And
so,
out of 1.78 million.
Yes, yes. We have, in fact, 7.33 million people in Hong Kong, citizens in Hong Kong. Only 1.78 million got tested. And out of those 1.78 million, only 32 new cases. There were about 10 confirmed cases, but they were old cases already. So they are not discovered by this screening maneuver.
And out of these 32, how many were symptomatic, how many were asymptomatic?
Almost all are asymptomatic or very mild. They are not serious at all. Over the past 2 months, over the past 2 months, 70 had died due to COVID-19. 99% of them were over 65 years old. So most of them were elderly who got infected in the aged homes. So unfortunate. It's all the old people who had died.
Thank you.
Yeah, thank you.
I request the chair to close the meeting by giving the final chair comments.
Okay, thank you, President, for that most enlightening session again. On Singapore's front, our dormitory outbreak is largely contained. We only have, as of yesterday, 11 cases. And for community cases, really is just a sprinkling of 1 to 0 cases daily. So we've more or less gotten everything under control. I'd like to correct Alvin on the vaccine. I think we are developing a vaccine, but I don't think we are anywhere in advance of phase 2 or phase 3 trials yet. So I think we'll still have to depend on other countries, first world countries and so on. As for today's session, again, a very enlightening session. Thank you very much to President and everyone participating today's session. And I'm glad to hear that we will be getting our CME points for this series of 25 sessions that everybody is engaged in so far. I look forward to next Saturday's session as per normal, and wish you all a very, very good weekend. Thank you very much.
Thank you, everybody.
Thank you, KK, and thank
Thank
you.
you very much. Bye-bye.
Bye bye, Azami. Thank you.